The Data Stories webinar series covers many topics related to oral health data and has been developed as a learning opportunity for open organizations and members to find and successfully use data to inform efforts in advancing oral health equity. The Data Network Response Team at Open recognized that our members have a wide range of content expertise and want to learn more about using data in their local context. In response to that need, the Data Story series was created to share innovations and solutions that are happening around the country that can help us to realize our collective vision more effectively and efficiently. We are excited to share this resource and look forward to an open and engaging dialogue that will continue after these stories are presented. Next slide. Today, we are proud to have Mary Jane Puffer, the Executive Director of the Los Angeles Trust for Children's Health. The title of her presentation is Using Data to Improve Access to Care Through School-Based Oral Health Programs. Mary Jane will describe this oral health initiative and how they have used data to advance their work at the Los Angeles Unified School District. Thank you for joining us.
Okay, it's a pleasure to be here and share this work. And I am a bleeding advocate for children's health overall, but also a serious advocate about oral health care. And it was data that got me there. Okay, so Francis is driving my train. So thank you, Francis, for that too. And so this session, we're going to talk about the LA Trust Oral Health Initiative and how we use data across the board to improve care. You should be able to talk about how our initiative began, how we use research and data to drive the program, how community has weighed in to develop the project, and then also a look at how outcomes are being measured and how we're advancing policy. Okay, next slide. So the LA Trust is a nonprofit that was created originally for LAUSD exclusively to advance student health and wellness, and that includes physical wellness, mental wellness, and oral health. And all of the programs that we build are based on best practice, evidence, impact, or community input. And then we also look at consistently quantitative and qualitative data to measure outcomes and drive change. And so I'm going to show you a unique system, and that is the data exchange that allows the district and the trust and program developers to actually look at provider performance, target investments, support funding and policy advocacy, and also keen insights for providers to also improve their own quality and access to care issues. And this slide, I'm not going to go through the whole thing because I really want to talk about the data exchange in our 30 minutes of precious moments. But the trust started in 1991, and there was actually about the ability for the district to gain investment in school-based health centers. And at that time, Robert Wood Johnson gave a grant to the district, and they needed a nonprofit to be the filter for receiving funding, and that's how we started. And eventually we became independent 501c3, but there was a strategic plan when I started in 2011 that had three aims. One was to advance school health policy. The second was to monitor and help manage the wellness initiative. So wellness centers are federally qualified healthcare center clinics on school campuses in the highest need areas in Los Angeles County based on population health, graduation rates, dropout rates, exposure to violence, poverty, etc. So we're super focused in those areas of highest need. And the third goal of the strategic plan at that time was to develop a district-wide health initiative, oral health initiative. And I was like, I'm a pediatric nurse to begin. We always did like rubbing the baby's gums when babies were in the hospital, etc. But when we did the first pilot test, which actually DentaQuest funded the original work, we found that 50% of our kids needed to see the dentist within 1 month. in 2 schools where we did the screening, at least 5 to 8% had abscesses or broken teeth, so level 3 sets of urgency. And I was like, this is a crisis. At the same time, the Diamante driver story was also like becoming very popular because of the egregious situation in healthcare for children, specifically oral health. So that was enough for us to like really get ramped up and focus on how do we solve for this problem for our kids in LAUSD. And so now, just to point out, there were 20 dental hubs. Francis actually was working with us at the time and helped do a lot of this mapping and establishment of the oral health initiative. So I want to acknowledge you for that hard work. We now have 17 wellness centers, and 6 of them have dental. And today, this afternoon, there's an oral health resolution with the LAUSD school board. So like, let the karma be with us to pass what we need to get passed. So I will talk about that in a minute. Okay, next. So here is the initiative in a snapshot. Okay. So we really did use a public health approach. So we were looking at community-wide education, early intervention, primary prevention. So like education for parents, students, teachers, universal screening and fluoride varnish, with a special emphasis for us in kindergarten students, because the incidence of this dental disease at early stages is like remarkably actually poor. So if we can get kids earlier and help train parents to, understand how to better care for their children's teeth, understand the antecedents, drinking more water, less sugary beverages, making sure that they have dental visits, etc., we can get ahead of it. So like, this is why the emphasis is on kindergarten students, but also to get more partners involved with the district, and also set up case management and referral for kids with high needs. And then really look at oral health policy in schools and statewide, and try to solve for how do we collect data to support this initiative overall. So those were the original aims, and they still hold true since 2002. Okay, next slide, please. Okay, so the implications for school performance. Now, this I think is the case making that we need to use, and we use data to drive it. So there was a study in 2012, USC, that found 2.2 days of school were missed due to dental pain in LAUSD students. LAUSD is the second largest school district in the country. So 588,000 students, 73% with untreated caries based on that study, times 2.2 days results in 945,000 plus days of school missed due to dental pain. And schools get an attendance rate about $70 per student, and that equated to $70 million lost to the district. So there was attention on this because of data and because of research and because of the study that was done by our astute colleagues at USC. Okay. And that began with the oral health program. So we talked to parents about what did they want, and parents wanted to be involved. So this is just a picture of the way this goes. So there's school education happening. There's tooth fairies that are parents in the classroom helping to move kids through. And then they all get goodie bags and are able to walk out of the room like healthy, happy, and whole, and connected to a dentist, and life is beautiful, right? Right. Okay, maybe not, but we try. Okay, so the Oral Health Advisory Board is a group that we pulled together early in the game. And again, I want to acknowledge DentaQuest around this, because the framework of care, community, finance, and policy was something that like really leached into my brain. So if we don't have a care delivery system, if people aren't available, nothing will happen. If we don't have communication and education with the community and partnership with the community, we can't advance the work. And if we don't have policy, and financing, which really was like the focus of the Oral Health Advisory Board, how can we move our system? So we've had an Oral Health Advisory Board since 2012, school staff, dental providers, advocates, parents, USC and UCLA researchers, promotor groups, county and state administrators to advise on program strategy. And our key target areas remain increasing access to oral care for students and advancing the kindergarten mandate. Undergirding that, of course, is education, and also, the access on more campuses. So Go to the next slide, please. So since that time, 2013 to 2019, this is the result. So this is the data, the way we collected the data before we had the data exchange, and we still, collect it this way to some extent. But the idea about giving the principal a report card that looks like a a blackboard report card was very engaging to the schools. So little touches like that really matter, I think, in the way communication is set out. So 17,000 kids screened, 68% with abnormal exams, caries experience in 66%, visible decay 32%, but urgent and emergent dental needs for 20%, or about 3,500 kids, is a tragedy that we have to intervene on. Again, motivating to move forward. So this kind of data is critical, again, for making the case with providers, with systems, with the school district, with funders, et cetera. And so this is where we were. So you can go to the next slide. And LA County did a SMILE survey in 2020 that included kindergarten and third graders. And, tooth decay is not in a good space, specifically for our Asian, Black, African American, and Latinx kids, which I think is a story across the country, where we don't have access, where we have systems that are set up not necessarily to serve universally. Our kids in the most economically disadvantaged neighborhoods suffer the most. So I think we have a social charge to respond to in this case, and we need data to drive that change. So under bullet point number 5, the results suggest from this study that 4,500 LA and kinder and third grade need urgent dental care. But from the slide I just showed you before, with a snapshot of the kids who had were arguably located in the highest need areas, that number is probably 10 times that, 4,500. So again, lots of work. Okay. So school board resolutions were a way to get to policy. And so, of course, our Oral Health Advisory Board presented all the time. We were arguing about this issue with attendance. Then we showed the disease prevalence and relevance. The county dental director, Dr. Kumar, who is now our state dental director, is involved. Our board members included Hal Slavkin, which many people know, who is just, a complete die-hard advocate for oral health in any way, shape, or form. So in 2013, the school board approved a district oral health initiative that included creating a district oral health nurse position to respond to that high need level 3 issue that when we discovered it. So somebody would be triaged right away. In 2017, the resolution to implement the program, including keeping oral health education in line with Children's Dental Health Month. So universal education across the district, expanding kindergarten screening, and supporting the development of automated dental reports was all part of that resolution. In 2020, finally, in January 2020, just pre-COVID, the board finally passed an opt-out consent for oral health screening in line with California Senate Bill 379. And so this, because it's in statute, was finally approved by LAUSD. LAUSD is the second largest school district and risk averse, but this was like a mammoth feat. And then COVID happened, and then all dental services shut down. So pretty much on school sites, with the exception of wellness centers, which is where I'm going to show you the data. And then today, the school board hears a resolution this afternoon to underscore the resolution and keep February as Children's Oral Health Month, but also ramp up the plan to ensure kindergarten screening is universal. So yay, pray for us. Our Tooth Fairy event was another one of our signature, it was an idea about honoring parents to begin with, the parents who participated in the screening. And now it is an annual event embedded in LAUSD's wellness fair, but providers come out and screen for free. University dental students do education. You can see we're Tooth Fairies. We fly around Dodger Stadium and, Potter the Otter encourages more water drinking. And so it's a really beautiful festival, but it deliberately links children and families to dental services. Okay. And so that's the initiative. And at the end of the slide deck, I have a bunch of resources which we can just plow through, but I want to get now to this data exchange. So we built the data exchange over time. So from 2013, we were doing landscape assessments about what kind of EMRs people have, how do they collect data, where does it go? And so we have 16 wellness centers that's full service community clinics open to the community and the school that submit data, including their dental data. And then we have attendance data from the district. So we're linking a student record to the health record. And we do this in a de-identified way, which is really remarkable. This is like unheard of across the country. So we have all these ideas about bringing insurance claims in and expanding the dental data to collect the dental data from all providers who serve LAUSD. And you can go to the next slide, Francis, thank you. And then we see from the data that we've already collected, there's all sorts of insights. You know, we need to look broader at our oral health data, but we can see when we look at absenteeism that of the children who are 12 years old seeking contraceptive services, there's a 62% increase in absenteeism. Tobacco screening also is a #1 health service that precipitates the decline. So you see, we can see from data that like advancing risk in younger students means that they will be less healthy. And so that should trigger a response on the school side to work for the providers to say like, maybe we need to talk to the parents and have the child more engaged in, you know, counseling, support systems, et cetera. So the idea about using data to drive this, but also for oral health, we can look at obesity tied to oral health and then really start campaigns that are program directed around healthier eating, active living, you know, not only oral health screening, but like those things that lead to poor oral health. So, you know, policy advocates, community coalitions, inner city struggle, the groups that we work with can look at this and like, why are our kids suffering so much? Why do we have these levels of disease in our kids? And what do we need to step up the game on? Okay, so go to the next slide. And we use the reports. So we use them to show to principals. We train student advisory boards in a boot camp to look at the data so they can see this sort of data for Carson High. You know, well, there's 1,700 unique patients that are served there and only 29% are students. So why aren't we pushing more of our peers to the wellness centers for comprehensive care? And today in a meeting this morning, Dr. Dudovitz from UCLA just presented some of the preliminary data with a statistical analysis that shows young children who receive services in wellness centers actually have better attendance. And that's not like a apple and orange situation, but at least it's like showing like access to care or understanding that care is important changes the game for kids. And so students use this to also like this slide on the Carson is a similar sort of situation, student and community services. And we can see diagnosis code. We could see the number of people who have asthma on this campus versus the other. So when we look at the whole landscape, I can see clinic A, B, C has really high rates of asthma and really high rates of oral health disease. What is that about? Because we know there's a connection between asthma and oral health. I mean, kids who are taking steroids and using puffers also have worse conditions. So how do we package that into a new program delivery? Okay, go to the next slide, please. And then this is just about the privacy of this environment. We have business associates agreements with all the clinics. The data comes in to the data helper behind a firewall of the clinic and the school. And then name, address, and zip code come in. So no health record. It gets a unique identifier in the privacy database. It goes back behind the firewall. The health data is connected to a unique identifier. It comes into the reporting database, and then we're able to regenerate on a 97% match between student and health record de-identified reports that are on the next slide. And we are HIPAA and FERPA compliant. We spent so much time on this. I think, you know, the idea about like trying to reinvent something like this, it's like, how do we make sure other systems, entities can actually benefit from the 7-8 years of work that went into developing this? Okay, go to the next page. So these are the dental reports. Go ahead. Okay, so we see, this is, can you see up on the top year 2021? This is the year of COVID. So like while other school-based health sites were closed, the providers who were in wellness centers open to the community were continuing service. We could track their service delivery over time. So you see that happening. The numbers of unique patients versus encounters results in 2.3 patient visits per year, which indicates a dental home. That's a proxy for dental home. And then we can see preventative service, diagnostic service, restorative services, age and ethnicity, diagnosis codes. So we can use this to sort of, again, drive like what kind of dental oral health program belongs at this school site where you see like really high levels of caries, but maybe no topical fluoride and no preventative service. We can look at that data and dissect that for provider performance. Okay, go to the next slide. And then this is really looking at like sort of the pediatric work and the numbers of encounters with dental screenings. It's 0 because it's filtered into all the other sites. So that's a little glitch in our system. We're trying to figure that out. But the numbers of encounters with comprehensive oral health exams, periodic oral health exams, fluoride, sealants, hygiene sealants, we got a lot of work to do. So we wouldn't know this unless we had this kind of data, and it's universal to the providers. So like there's going to be discussions about sealants with providers as a result of this. And okay, go ahead to the next. And then this is related to kindergarten mandate. So we want to brush this up actually with Dr., no pun intended, with Dr. Kumar, and make sure that like this, you know, the numbers of encounters with caries at recall, when you look at this 0 to 5, we're so happy to see the numbers of 0 to 5, because these are communities where we've been encouraging earlier intervention. So I think some of the influence of the advocacy for early intervention is happening here. But you know, it's not better in 2021. It's worse in 2021, and so that could be as a result of COVID. But then encounters with high risk, moderate risk, and low risk aligns with the kindergarten mandate. So we're going to work to align that with whatever comes up in the system for SCORE, which is the California system. Go to the next slide, please. This is old. We don't have this clinic comparison yet, but I just put this in here to show you that we can look at each wellness center and compare how much data we have, how much dental service are they providing? Because from an administrator's perspective, I would want to look at this and say, like, I have money from my school district to be able to invest in joint use funding to build a new clinic somewhere. And I'm going to partner with whoever the provider is at Jefferson, because they know how to do this, or at a minimum, have Jefferson really do an orientation to the provider about how to do this kind of service. So again, implications for practice, policy, and so on. Go to the next slide, please. Okay, so real-time data, monthly downloads, seamless from the EMR. It's like seconds, 5 minutes it takes to upload once we get the data helper in place on the clinic side. We can see the services based on population health. It's connected to a student record, so we'll be able to show long-term impact based on diagnosis code and treatment. And go to the next slide. It's used by students to promote oral health and access to care, principals to monitor the efficiency of their partnership and the impact on attendance and grades, administrators to identify gaps in services, the Oral Health Advisory Board to actually monitor access and quality of care, for the Dental Providers Society to understand like the impact of student-based, school-based performance, child advocacy groups to expand access, and parents to understand the importance of oral health to their children's ability to succeed in school. So students can show this information to their parents, and as peer advocates, it's like beholden to them to be able to do that kind of education. And we see that with young people over time. Next slide. And that's it. So there you go. And I guess if we have questions.
Yes. Well, thank you so much, Mary Jane. That was just absolutely informative and excellent. As a matter of fact, we have a couple of comments in the chat box on greetings from Oregon and Pennsylvania and New York and California and Tennessee and more, and that you've done an incredible work But one of the questions that we have is from Teresa. Teresa, you want to ask your question directly, or you want me just read it as it was in the chat box? Well, maybe she can expand upon it, but for the sake of time,
I
she
can
said,
answer.
oh, okay.
Yeah,
Why
I
an
can.
oral health nurse? I'm sorry.
Yeah, I see the question. I can take it.
Okay, there are some people that's just on phone and can't see the chat. So let me read the question. Why an oral health nurse and not a registered dental hygienist?
You know, this is a ridiculous bureaucratic answer, and it's a real bureaucratic answer that the district did not have a human resources category for a hygienist. And they argued that the time it would take to get a hygienist position certified through the district, they decided not to do that. So, you know, it became a district oral health nurse. And honestly, I think when they saw the data, and this is like my supposition, but when they saw the level of disease, they needed action, and we needed somebody who was going to connect kids to care, like through the parents, that was trusted. So I think honestly, it was like the path of least resistance for the district. It's not that a hygienist doesn't belong in this position. And I think now they're starting to look at how do we use hygienists, because the nursing shortage is just ridiculous.
You're on mute, Sherry.
Sorry, I've got some work going on outside and I can hear it. Is your data system available for other programs to utilize?
It totally is. And I would be happy to have that kind of a conversation. I mean, we would, of course, have to figure out like what the business cost would be for that situation, but it's already built. That's where I feel like there's an opportunity to leverage this investment with other systems. And so I'm happy to have that conversation offline.
Okay. So another question is, maybe I missed the name of the software program your school system is using. Can you share that?
Yeah, I mean, we call it the data exchange. And so the school, if you mean what system LAUSD is using, they use Welligent software. I don't know if that's universal or that's California only, but it's called Welligent. That's what the district uses.
Do you think this information will be available later for us to post?
Oh yeah.
Mary Jane? Yeah, okay,
Yes.
fantastic. And Teresa did have a comment back to you. She said, apparently, I am either the only or one of the only RDHs hired by a school district.
Yeah, and I think that's a problem. I think we have work to do there because, again, you know, I mean, RDHs can manage the kindergarten mandate, and district nurses are in the middle of doing COVID vaccination and all these other things. They've been pulled offline for the last 2 years. So like even now the discussion around moving back in with a district oral health nurse is not probably going to happen now.
And some of the chats are going so fast. Did I read what credentials do the oral health nurse have? Are they RDH or assistant?
No, the screening was always done by dental providers. So hygienists and dentists did the screening, but internal to the school was the district nurse because she had access to the school record and was able to contact the parents.
Okay.
So a school RDH would be able to do that as well, but the district pushed back on that when we started this initiative.
Okay. And Donna Murray responded to Teresa. She says, I too am a school dental hygienist. I was able to secure an emergency certification through Pennsylvania Department of Education, having a minimum BS degree.
Mm-hmm.
Okay. And let me see. And from Family First Health in Pennsylvania, we would like to have additional conversations offline on the availability of your program.
Yeah.
Okay. And she provides her email address. Okay.
Okay.
Are there any other questions out there that's not in the chat box?
You know, I actually have a question, and it's about pediatric performance measures. And that is something that I hope that we can work together on. The National School-Based Health Alliance has performance measures that are aligned with HEDIS standards, but we don't have that for oral health. And so like we looked at NOHA and also, the kindergarten mandated screening parameters, but like maybe this is something, we all can work on together, is happening now with open. But that's critical. That would be if there was a national measure, that would be beautiful. So let's do it, Sherry.
Can you expand on the issue of oral health advisory boards?
Right. So I feel like if we did not have that kind of clout when we started, we had data to begin with, but if we also needed the clout. So like having the conversation with like Children Now, the Children's Partnership, the Promotora programs, the parent groups, the health plans, the researchers, all of those people at the table got behind that. So when these resolutions came through, there was a lot of expertise behind it in this field. And I think that matters. We're going to move the agenda.
Okay. Anybody else? All right. Again, I want to really thank you, Mary Jane, on behalf of the Network Response Group, the data measurement team. And Francis, do you have the date of our next data story and the title of it?
I believe that it is on March 20 or March 2nd, and I'm dropping into the chat the page on our website at openoralhealth.org. We have an events page that has all of the data stories that are coming in the next few months.
Fantastic. Okay, and then I think this might be one last question. Can you expand on the issue of oral health advice? No, I read that one. How was Sesame Street onboarded?
Okay, so they actually were part of really the original wellness initiative. So we met people from Sesame Street back in 2012. And they work very closely with UCLA. So Dr. Jim Krall is really involved with them on a national level. So a lot of their oral health videos were like guided by Jim Krall. So there was an LA connection to Sesame Street, but their materials are stellar. And I mean, I would reach out to them and try to get their support, because that's critical. We also have resources I put in the end of my slide deck. So we have an oral health toolkit. We have, videos and those sorts of things that we are certainly happy to share. And I just want to thank everybody for listening to my rapid fire.
Fantastic. Okay, Grace or Francis, have I forgotten anything or?
All good. Thank you so much.
All right.
Thanks everybody for joining us.
Thank you. Bye.
See you.